Welcome everyone. Great to see you all here today. My name is Catherine Goodman and I'm from the London School of Hygiene and Tropical Medicine in the UK. A warm welcome to this session on healthcare market competition in low and middle income countries. As I'm sure you all know, there's a long history within health economics of studying the impact of competition on healthcare quality and price. And these questions are really pertinent in many LMIC contexts today, particularly where the private sector plays a very important role in healthcare provision, whether that's through out-of-pocket purchasing or increasingly as a part of purchased care under social health insurance. It's a fascinating area to study because there are many challenges methodologically, particularly in measuring competition. And in these contexts, it can be particularly challenging because there's relatively little good routine data available to use for competition measurement. So in this session, we're going to be exploring some of these measurement issues, as well as looking at empirical findings on the relationships between competition and market outcomes, and also considering the policy implications. And we're going to do that through some examples from Georgia, Kenya, Uganda, and Tanzania, and Indonesia. So we have 4 presenters today, Mari, Sarah, Tim, and Rebecca. They're each going to present for 8 minutes. And then we have 2 discussants, Soren and George, who are going to be reflecting on what they've heard and giving us some initial reactions. And then we'll open the floor for a general Q&A. Feel free to put your questions in the chat box as we go along. So just add them as and when they occur to you. But we'll save all the questions up for responses after all the speakers and discussants have spoken. So I'm required to remind you that the session is being recorded. But otherwise, I think we are good to go. And I can hand over to Mari, who's our first presenter. So over to you, Mari.
Thank you, Catherine. My name is Mari, as Catherine has mentioned. So I'm from Grigori International Foundation from Georgia. So I'll quickly share my presentation. I'm honored to present on behalf of our project team from Grigori International Foundation and from London School of Hygiene and Tropical Medicine. So the work we are presenting today is part of a broader research, but today we'll only focus on a quantitative analysis under the research question 1. We studied the structure and the nature of the Georgian healthcare market. So Georgia is a small former Soviet country that has undergone an extensive privatization since 2007, where the public expenditure is just less than 30% of total health expenditure, and over half of the expenditure is out of pocket. And that's despite the fact that there is a universal healthcare coverage program in the country, which was introduced in 2013. Well, the introduction of the UHCP program was accompanied by a big increase in supply. You can see on the left-hand side, large increase in hospital beds, which is kind of a reflection of the very low barriers to the market entry. And then we have this long-term trend of increase in utilization of healthcare services. But it's worth noting that even with this growing rate of use of the overall per capita utilization rate, it's still less than half of the European average. So now I'm going to move and speak about the methodology section. So I'll focus on a product market definition as a first step. So we decided to focus on 2 separate service markets. The first one is the inpatient market, and the second one is the outpatient market. So we used the basic and more advanced bundle of service components available under the UHCP program. So it's worth mentioning that 97% of all hospitalization cases is reflected under the UHCP, and 92% of all outpatient visits. To give you a brief understanding what these facilities are, So at the top on the left-hand panel, you can see that there is a large number of low-volume providers. They provide up to 5 daily admissions and have the market share of 23% by inpatient hospitalization daily admissions. And also we got the similar pattern for outpatient market in the below, where you can see that the low volume providers account for 40% of the market share. So we talked about the facilities as an independent providers, but in Georgia, a lot of facilities are networked. So for example, in inpatient market, we have 88 facilities which are networked in the 4 large networks, and they account for this 35% of the market share. And then we also have some standalone facilities in the inpatient market where they have the larger market share. So we've got the similar pattern for LP market, where the large networks account for 41% of the market share. Well, another important decision which we made before the analysis was the geographic market definition. So there are lots of approaches to define geographic market, but we decided to choose the travel time. So we are using 2 different travel times based on the settlement size. We chose 10-minute travel size for cities with more than 100,000 inhabitants. We've got the capital city and big cities, and for small cities and settlements, we're using 30-minute travel time. And this table shows the geographic grouping which we're using for the analysis. So to move on and speak about our last choice that we made was the competition measures. So within the isochrone, we measured a Herfindahl-Hirschman index, and we are using these normative thresholds according to which the moderate concentration is over 0.15 and high concentration over 0.25. And we also looked at the concentration ratio for top 3 facilities and the number of competitors. And also we calculated the travel time to the nearest third provider, but this is not an isochrone-based measure. And at the bottom panel, we can see the data sources which we use for our analysis. So to talk you through some of our results, I'll start with 2 of the simpler competition measures with the outpatient market. And one thing to mention that we are providing all our results separately for each settlement size. So to remind you, the SS1 represents the capital city, then we have the large cities, SS2, then comes small cities and small settlements. So to start with the number of competitors, you can see that the local competitors is high in all settlements. And when we increase the travel time here, the number of competitors still remains substantial. It's 10 in small cities, but it's only 4 in small settlements. And as for the travel time, it takes 3 to 4 minutes to reach the 3rd nearest competitor in SS1 to SS3, but then in SS4 in small settlements takes 24 minutes to reach the 3rd nearest competitor. This was the results for outpatient market, and for inpatient market, we've got the similar pattern, but it just takes longer. The median value for a small settlement is over a 30-minute travel time. Okay, so I'll start again with the outpatient market here, and here we incorporate the market share information to look at the concentration. So as you can see, in this settlement, in these 3 settlements from SS1 to SS4, the top 3 facilities are leading the market, and they are dominating the market. But in capital city in Tbilisi, our median value is less than 50. So we've got this similar pattern for HHI value, and if we refer to the medians, we can call that the settlement sizes in SS2, SS3, and SS4 are counted as a highly concentrated, except the SS1, which is capital city and which is regarded as less concentrated market. So as for the inpatient market here, the top 3 facilities on average are covering the whole local geographic market in small settlements. So with this slide, we just want to take a brief look at vertical integration because before we only covered the horizontal integration, and we plan to use this information further in the analysis in the future. So I will just quickly wrap up what we have found. So we ended up with naming Georgian market as concentrated and fragmented at the same time because we faced that we were finding those things, but in different places. I will list each evidence of fragmentation and concentration because we already touched this based on our results. So to move on and say a few words about our next steps. So we are using this presented data to intend to further explore through qualitative research and to understand what harms and benefits are for such markets in the Georgian context, and also to test our harms and benefits using the regression models adapted to our purposes. And with this slide, we want to acknowledge our funder, the Health System Research Initiative. I'm over, thank you.
Wonderful, thank you, Mari, and perfectly to time, which is very impressive when explaining so many of the complex methodological choices you have to go through when assessing competition. So without further ado, straight over to our next speaker. So Sarah, please set yourself up. And just a reminder that you can put questions for any of the speakers in chat as we go, and then we'll come back to those at the end. Great, Sarah, over to you.
Hey, can you see my screen?
Yeah, that's good.
Okay, good. So hi, everyone. It's a pleasure to be here. This work examines the effect of competition on markups for malaria treatment in the context of a large and controversial subsidy intervention. So malaria is a curable disease if treated promptly. The recommended first-line treatments are a drug class called artemisinin combination therapies, or ACTs. They combine an artemisinin derivative with a partner drug. ACTs are officially free in the public sector in most countries. However, many people seek care in the private sector where a less effective class of drugs, non-artemisinin therapies, are widely available and much less expensive than ACTs. So specialized drug sellers are the main source of antimalarials in the private sector in most countries. So specialized drug sellers are businesses that primarily sell medicines. They include pharmacies and drug shops. So there is a lot of interest in improving the quality of malaria case management in the private sector. And the most prominent example of this is probably the Affordable Medicines Facility Malaria, or AMFM. So in essence, AMFM was a subsidy paid to international manufacturers of ACTs that met certain quality standards. The subsidy was in the form of a co-payment where the Global Fund paid 95% of the drug cost, so that importers in participating countries only had to pay the remaining 5%. And the idea was that through the magic of competition, the subsidized quality assured ACTs would travel through existing supply chains and would be widely and cheaply available like the non-artemisinin therapies. So this study is set in 2 countries that implemented AMFM. And there are important differences in AMFM implementation and performance across the 2 countries. So Kenya really was the star performer. It had the most improvement in various metrics that were assessed in an independent evaluation. There are substantial improvements in the availability of quality assured ACTs, market share, and large price reductions, as well as good promotion and adherence to recommended retail prices. In Uganda, by contrast, was a bit of a mixed performer. There are large improvements in availability and market share of the subsidized medicines, but only modest decrease in price. And an important contextual factor is that there is actually no promotion of recommended retail prices. So economic theory suggests that markups and prices will be lower in competitive markets. We suspected that the relationship between competition and markups would differ across the study countries due to the differences in the promotion and adherence to recommended retail prices. So we examined two hypotheses in this piece of work. So in particular, we hypothesized that in Uganda, where there was no promotion of recommended retail prices, we would find that markups would be lower in areas with high competition for both subsidized and unsubsidized drug classes. In contrast, in Kenya, where there is strong promotion and adherence to recommended retail prices, we hypothesized that there would be a negative relationship between markups in competition for non-artemisinin therapies only, so that's the unsubsidized group of drugs, and that there'd be no relationship between competition and markups for the subsidized class of medicines, so the AMFMs, quality assured ACTs. In low and middle income settings, there are essentially no complete lists of specialized drug sellers. So we used ACT Watch data from 2012, and this data set had a cluster sampling approach, or a census approach. So within each of the selected clusters, we have information on all anti-malarial outlets. However, outside of the selected clusters, we have no information on the location of any specialized drug sellers. And so this is just an example of a map of some clusters around Nairobi. The red outlines show the selected clusters, and the dots show public and private outlets that stock anti-malarials. And as you can see, there's a lot of variation in the size of clusters between more rural and urban areas. So a key theme of this project is that I have these rich but imperfect data. And so since I don't have information on the location of all pharmacies and drug shops, like you would typically have in many high income settings, it was not feasible to use common spatial measures of competition that measure competition at the level of each provider. So instead, I used an administrative boundary approach to define markets. And I measured competition as the density of providers per kilometer squared in the market area. So our empirical approach was to model markups as a function of market competition, controlling for a set of product, outlet, and area characteristics with cluster level random effects. And because the main data set consists of information on outlets and the drugs that they select stocked only, I used the GIS coordinates of the outlets to link to auxiliary data sets to get data on characteristics of the outlets area, which had factors that could affect the supply and demand of antimalarials. I'm not going to spend a long time going over summary statistics, but I wanted to highlight two things here. First is the level of markups, which were about 50 cents on average in Kenya to about $1 on Uganda. The total drug, or the average drug cost was about $2 across the different drug classes. And second, there is a wide range of competitor densities. So some areas were very sparse, while as you can see, others are highly competitive with up to 22 competitors per square kilometer in Kenya and twice that in Uganda. So if you recall, I expected competition to have a negative effect on markups for all antimalarial classes in Uganda. And that is exactly what the results showed. So markups are about 1 to 3% lower for each additional competitor per kilometer squared across the different drug classes. In Kenya, by contrast, I expected competition to have a negative effect on markups for non-artemisinin therapies only. And my results are basically the exact opposite of what I expected. And results are identical if I use price as a dependent variable instead of markups and across various model specifications. So obviously the Kenyan results were not expected, and there's many possible explanations. It just could be that our priors were wrong and our hypotheses didn't adequately account for the market distortions caused by AMFM in Uganda, or there could be a number of issues with our data or empirical approach. So to conclude, we found evidence supporting our hypothesis for Uganda, but not Kenya. And I'm finding it difficult to untangle the Kenyan results due to data limitations. But there are a couple of policy implications. For example, the concerns voiced by AMFM's detractors that retailers were earning extra profits on subsidized drugs may have been warranted in areas with low competition. And there might be some broader implications for interventions that seek to leverage competition in the private sector. Thank you.
Wonderful. Thank you very much, Sarah. So from 2 countries in East Africa to a 3rd East African country, I'm going to hand it over to Tim, who's going to move us on from retailers to competition amongst healthcare facilities in Tanzania. So Tim, over to you.
Thank you very much, and thanks for inviting me to this session. So our paper is called Healthy Competition, Market Structure and the Quality of Clinical Care in Tanzania. And my name is Tim Powell-Jackson, and I work at the London School of Hygiene and Tropical Medicine. And we did this work in collaboration with the Ifakara Health Institute in Dar es Salaam, Tanzania, and Farm Access Foundation, who are based in the Netherlands. So just to give some background in terms of the big picture, it's pretty well accepted that poor quality of care is an important determinant of excess mortality, and some various modelling exercises have been performed at the sort of cross-country scale, estimating huge numbers of deaths are caused by poor quality of care. And it's also widely acknowledged that private providers in low and middle income countries are an important source of care. It's sometimes difficult to get good data on this, but the DHS surveys provide some data, but obviously they're particularly focused on children and maternal health care. And so it's true to say that most health systems in low and middle income countries are pluralistic. And in many countries, the private sector is indeed growing as these countries, as their economy grows in tandem. But you have a huge range of private care provision, from small clinics to large multi-speciality hospitals, and this market segment is likely to increase. Now, private sector advocates have long argued that one of the benefits of the private sector is that market competition drives these providers to become more efficient and responsive to patients. And by responsive, I guess you could also include improves the quality of care. But actually, when you probe the theoretical literature carefully, the relationship here is ambiguous when prices are not regulated. The theoretical predictions are much more clear when prices are regulated, but when they're not regulated, it's not clear what the relationship is between competition and quality. And actually, these models, the predictions of these models come down to very fine details and very sort of specific nuances. And then when you look at the empirical literature, it's mostly limited to high-income countries, but the evidence there is very mixed in terms of the relationship. There are a couple of studies from low middle-income countries, but they are few and far between. So the purpose of this study was to examine the relationship or link between healthcare competition and quality of clinical care in Tanzania. And I emphasize the clinical quality of care because this is one of its main contributions, is to use some quite interesting data on the clinical quality. The study setting is Tanzania, where the health system is pluralistic. Quality of care is generally low. There's certainly not much information available publicly on the quality of care, and insurance coverage is pretty low. And our sample comprises of facilities in both the for-profit private sector and the faith-based not-for-profit sector. And we're using cross-sectional data that was collected as part of a different study, actually, which was looking at, it was a randomized controlled trial of a quality improvement intervention, but I'm not going to talk much more about that now. And so in terms of our outcomes, we use standardized patients, which some of you may be familiar with. So these are healthy people who go in as fake patients, essentially, pretending to have certain symptoms, and which is all very structured, and they're very well trained over a 2-week period. And from this, you can get measures of clinical quality. And so our main measure is correct case management. And this is based on national treatment guidelines. We have a strict definition, which has got to be correct without any unnecessary care. You can have a looser definition that allows for correct treatment with unnecessary care. We also have an outcome which is unnecessary care, which is a kind of almost a mirror image of correct treatment without unnecessary care. And we've also got another outcome, which is adherence to an essential checklist of questions. So these are items that the provider are meant to do. We've also got some data from a different source on patient satisfaction, and we have data on prices as well, out-of-pocket expenditure in the visit. In terms of our measure of competition, we use data from a census of all healthcare facilities in Tanzania, which is quite an unusual source of data to have. So it geolocates every single facility in the public and private sector across the whole of Tanzania. And our main measure is a geographical measure. It's the number of healthcare competitors within 5 kilometers of a study health facility. And we put this measure into categories because it's highly skewed. So no competitors, 1 to 5 and 6 or more. We've then got a rich set of covariates, cost shifters, and more on the demand side. And so this is a cross-sectional analysis in which we're running a regression of the quality, as mentioned previously, on our vector or indicators of competition, controlling for characteristics of the facility and the local area population. And we're also including standardized patient fixed effects. One thing to note here is that by using standardized patients, we are effectively controlling for patient case mix. Okay, so because we have sent in the standardized patients, compared with other studies where your measure of quality is coming from, say, medical records, where you've got the potential confounding risk of age, gender, and other characteristics of the patient that might affect quality. That's not the case in this study. So here we just got some basic data, so you can just get a sense of the basic descriptives. So here you can see that correct case management, when we use our strict definition, it's very low, it's 8%. A looser definition of correct case management, in which you allow for unnecessary care, it's close to 30. Unnecessary care here is just over 80%. So in 80% of visits, our patients are getting unnecessary care. And then we've also got a measure of the checklist items. And so these are our core results from the different regressions as per the different outcomes. We've got essentially 2 sets of regressions in which you have basic facility controls and then a richer, in panel B, richer set of controls. So we focus on the richer set. As you can see, number of competitors 6 or more results in a reduction in correct treatment by 7 percentage points. There's a sort of mirror image here of an increase in unnecessary care of 11.6 percentage points. So those are our core results in quality. And then we have a result which is showing that the more competitors there are, the lower the prices. And this applies to a number of 6 competitors or more. So to summarize, quality of care is low across the board, and greater competition is associated with lower correct treatment, so worse quality of care, higher unnecessary care, and lower prices. There's certainly some limitations here, which I'm happy to talk about later. I guess some key implications from this is that providers seem to respond to greater competition by increasing unnecessary care, which plausibly is very visible or observable to the patient. And results suggest that patients are sensitive to price. Thank you very much. We've got some references there if you're interested in scanning later. Thank you very much.
Wonderful, thank you, Tim. And without further ado, over to our final presentation. So Rebecca's going to take us to Indonesia and tell us about the evolution of competition there under the National Health Insurance Scheme. So off you go, Rebecca.
Thank you. Hi, my name is Rebecca Ross from the USAID-funded Health Policy Plus project. Today, I'll present findings from our assessment of the impact of the introduction of Indonesia's National Health Insurance Scheme on private sector. Before we dive in, I'd like to set the country context. The government of Indonesia initiated JKN, its National Health Insurance Scheme, in January 2014, aiming to achieve 95% coverage in the first 5 years. As you can see here, they achieved a relatively speedy start as they wrapped other social schemes on health under the JKN umbrella. And there was an estimated 77% of the population enrolled by 2018. The private sector has been an important source of healthcare in Indonesia, and the number of private hospitals has increased while public sector has remained relatively constant. Private hospitals now make up over half of the facilities contracted to offer services under JKN, and the Indonesia health system relies on private manufacturers and importers for essential drugs and medical devices. So the private sector is well placed to respond to increased demand for health services and is essential for successful achievement of universal coverage. That said, private sector must be appropriately incentivized to engage within the scheme, and engagement must ensure high quality while controlling cost. Palladium, through the USAID-funded Health Policy Plus project, partnered with the government of Indonesia's national team for accelerating poverty reduction to conduct a multi-scope assessment of the national health insurance policy. One element of the study included the impact of JKN on the private sector. We had the overall goal of understanding how JKN affected growth in private markets, incentivized investment, and increased competition, and whether this would allow better options for the consumer while maintaining costs to the payer. The study focused on pharmaceutical manufacturers, medical device manufacturers, and private hospitals. We used a mixed methods approach. We gathered some secondary data, including publicly available market data and surveys. We also had permission from the government to use some of their data. We conducted 27 key informant interviews with pharmaceutical companies, medical device companies, hospitals, and clinics. And we conducted a hospital survey among 73 private hospitals. So I'll go through now some key insights emerging out of each of the 3 target subsectors. First, to provide a brief overview of the pharmaceutical sector. It's the largest market in the ASEAN region, and the outlook prior to JKN initiation was favorable, with the market split between multinational companies, which tended to focus on patented drugs, and domestic firms, which tended to focus on generic drugs. The industry expected a positive economic benefit of JKN because of the guaranteed increase in patient access to care and higher treatment volume, and a centrally managed procurement system. It is also expected that with JKN, there'd be an emphasis on low-cost generic drugs. There was no change in number of pharmaceutical companies in Indonesia, but we found the sales volume increased since JKN implementation. Generic and patented drug sales increased by about 20% and 27% respectively, though the breakdown between generic and patented drugs did not change, as seen on the left. Illustrated on the right, the expected increase in sales volume was not really realized by many multinational corporations, though local firms had seen sales and growth. And while branded drug prices increased, generic prices have decreased. In response to that, multinational corporations focused on branded and prescription branded pharmaceuticals, while local companies focused on generics. And with the use of the e-catalog, the online purchasing platform for supplying public health facilities, competition has increased among domestic firms, particularly in terms of price, which is what's driving selection on the e-catalog. But key informants highlighted the lack of transparency and coordination around prices on the platform. And with its single winner policy, there's sort of a disincentive for the Food and Drug Control Agency to monitor firms. And furthermore, with the lowest bid winner, there's some concern that there may be new lower quality or limited supply of needed drugs. Moving on to the medical devices, the market was dominated by multinational corporations and dependent on imports to meet demand, which was concentrated in Jakarta, Indonesia's capital. With the introduction of JKN and the influx of populations accessing a wider spectrum of health services, sales volume was expected to increase, especially in new geographies. As with the pharmaceutical market, we found that the number of medical device manufacturers remained relatively stable. And with respect to product offering, following JKN, the medical device market grew and was expected to continue growing. The largest growth was in diagnostic imaging with 56% growth and consumables, 40% growth, shown on the left. We also found that the Indonesia case-based groups, the INA CBGs, reimbursement rates could influence medical device use by providers, incentivizing the use of most cost-effective devices and consumables, seen with an increase in sales of simpler and less expensive treatments. E-catalog was lucrative for fast adapters who listed products early, getting a larger slice of JKN hospitals and patients. The e-catalog became a price benchmark even among private facilities that could not purchase through it. So there's urgency to be listed on the catalog, and competition increased significantly. With increased competition, medical device firms needed to build brand recognition and loyalty with clients. For private hospitals, the market has expanded, with growth driven primarily by for-profit sector. Primary care facilities act as a gatekeeper, referring patients up. And with JKN initiation, the healthcare service delivery industry is even more attractive. And it was expected to have more private providers enter the market, and capital investments and service expansion to be incentivized by attractive tariffs. As illustrated on the left here, private sector grew, but not as rapidly as expected in eastern provinces. Growth in Java and Sumatra provinces was dominated by private hospitals, but the public sector drove expansion in rural provinces. The composition of total revenue shifted away from out-of-pocket and toward greater reliance on insurance from contracted hospitals, as shown on the right, but providers explained that profitability was driven by offering more basic care, not expansion of services. Key informants noted the lack of transparency in the reimbursement rates, making it difficult to align their costs against reimbursements. And regardless of ownership type, private providers did not have negotiating power on the reimbursement rates. This is established a monopsony rather than private providers concentrating power. And while the economy of scale achieved by networked hospitals is strong, they remain a minority, and the private provider market remains fragmented. The focus is on cost control and not necessarily quality. JKN as a buyer has impacted price and choice in the three subsectors differently, motivating varying levels of competition. While JKN has stimulated the private health market in most of the country, the primary change is on cost reduction and volume growth, rather than incentives for investing in service diversity and quality. The difference in perception of the pharmaceutical and medical device marketplace indicates a need for further refining a strategic purchasing mechanism that provides choice and incentivizes quality. Healthcare is a unique market, and as this case in Indonesia shows, requires careful interventions beyond payment incentives to create a competitive market that leads to social benefits. Thank you.
Oh, wonderful. Thank you so much, Rebecca, and thank you all of our four presenters. Being online is wonderful, but I do miss the opportunity for a good round of applause, definitely merited, for really interesting presentations. So I'm going to hand over to our two discussants, who are both going to just give a few minutes of reflection and reactions. So beginning with Søren Christensen. So Søren, please do introduce yourself and tell us what you thought. Over to you.
Okay, so my name is Søren Christensen. I'm an associate professor in health economics at the University of Southern Denmark, and I want to thank you for the invitation to comment on this, and thank the authors for four really interesting papers. We saw evidence from 5 countries and 3 sectors, and I think we learned a lot already in a short time. So to begin with, Mary showed us 4 ways of measuring competition, and I think these can be useful for any study in this area, because depending on the level of data availability you might have, you can find a way of going there in terms of how you can go about measuring competition. I think one thing that wasn't emphasized so much here, but is in the wider set of slides I had an opportunity to look at before, is a really interesting question, namely this question about market concentration versus fragmentation. And I think many times in this literature, we focus on competition, or there's expectations that greater competition might be positive. But I think you also raised some important questions about whether we could get to a state that's too fragmented. And I think that's really interesting. In the high-income country literature, which I'm more familiar with, there's now questions that are similar when we talk about integrated care, and we begin to think about whether care integration is actually, how should we view that in relation to competition as well. So I think interesting question. One way to think about it, if you want to think more along that route, could be to think about the implications from a patient perspective and from a system perspective, because I think to some extent for patients, obviously a fragmented care system might be very bad, but from a system perspective, yeah, we might see that multiple providers could have a positive impact on cost. So I don't know where to go with that, but I think maybe that distinction when you make the discussion could be interesting. And Tim, you mentioned that theoretically we can make some expectations about what the impact could be from improving competition. And one of the insights that you also spell out more clearly in the longer slide set is that the expected impact partly depends on the elasticity of demand with respect to quality and the elasticity of demand with respect to price. And so I think in your study, you found that prices dropped more in more competitive markets, but the rate of unnecessary care increased. So taking that back to the theory, I think that indicates that maybe the elasticity of demand with respect to prices is greater than the elasticity of demand with respect to quality. But it also made me think about, in all of these studies actually, what is the information that's available to patients? Because if patients haven't got information about prices or quality from different providers, how can they actually make a choice? So I think there's more things than just number of providers that needs to be in place to enable competition. Information is also important, and maybe there could be some potential for interesting studies there to look at the information that's available to patients across the countries. In that respect, I thought that Sarah's study was really interesting because she has two case studies, one which is with and one which is without regulated prices. It's not really regulated prices, but there is, in one of the countries, you have these suggested prices, retail prices. But actually, you found the opposite of what you would expect for the semi-regulated prices. So it's interesting to try and figure out what could be the reason for that. And I'm afraid I also couldn't think of exactly what it could be. But I did wonder whether you could use some of the methods to define market areas from the first study we saw, because I noticed that obviously there's data limitations always, but there were alternatives to using these administrative boundaries to define market areas. So maybe there's something to look at there. And then finally, and I'll stop now, a general comment is that many times when we are trying to investigate the impact of market structure or competition on quality or prices, we might be worried about endogeneity. And so we will try to be looking for sort of external or exogenous variation. And in that sense, we actually saw that Rebecca's study had exactly that, because you had this big health insurance reform. So that was a nice example of an exogenous variation that gave some of that variation that we are looking for when we are studying this empirically. And here I would just say that I think a really interesting next step would, of course, be to look at the impact on patients' health outcomes as well. Your study focused a lot on the market side of things, but I think then taking it to the next step, we're looking at health outcomes could also be interesting. So sorry for being brief and and talking too fast, but that was the task.
Thank you. Yes, absolutely. That was the task. And you crammed loads of fascinating insights and reflections into a very short period of time. I'm going to hand over to our other discussant. So over to you, George. Please introduce yourself and give us a few brief reflections.
Thank you, Catherine, and thanks to presenters. I'm George Gotsadze, a colleague of Mari, working in Georgia, but also beyond. So for past quarter of century, so in many different jurisdictions on health policy and systems issues. I'm also associate professor at IHEA State University in healthcare finance and policy issues. And first of all, thanks. And I think like the first thing that Tim has clearly highlighted in his slides, the private sector is there. So while it has been for some time ignored, so we're recognizing its existence and also its importance probably going forward. And we're taking the first steps in market competition, as Tim said, like international literature is rather shallow, like from the findings or rising findings from low and middle income countries. And this is a great contribution. So congratulations for picking this topic. So Soren said, and probably like we have seen the challenges of defining the competition and measuring it, and especially like defining the boundaries, the competition, what measures to use, how challenging it becomes. And we've seen the 3 studies. So all dealing with these issues, finding different ways, but probably it would be also warranted going forward to work on the methodological aspect. So more countries and more researchers get guidance how to deal with this challenging topic in a data constrained or limited environment, and how challenging and data intensive it might be for others to adequately plan for their research programs. So, and that was good to see across the set of the countries. The next one that raises this fundamental question is competition good for quality or not? And as it has been mentioned, the literature that is available largely from high income countries is more conclusive, like when the prices in the system are fixed, but less conclusive so or ambiguous, like when there is a free market or free prices. And looking at the large range of the countries where a significant portion of the health expenditure is borne by the households, the issue of how to deal with the private sector in an unregulated market where prices are not set becomes even more important for future exploration and research to better understand, because the coverage rates with the state-provided guaranteed services, as we know in many low and middle income countries, is rather low, and most of the health services are paid on an out-of-pocket basis. Therefore, so that gives probably the freedom of the market players and private sectors that are largely driven by revenue, or we could say like profit maximization, to behave differently in that, like provide less or more unnecessary services, as we have seen the case in Tanzania. We have not presented, but this is now coming forth, like in Georgian study as well, that there is a degree of supplier-induced demand providing unnecessary services, which may on a personal level would not cause the damage to the health of a patient. I don't think theoretically like doctors are individuals who would cause the damage to the health, but if these services are paid by the patients or even by the purchasers, state purchasers, then we'll have a bigger societal impact. And going forward, probably unpacking these topics and these issues through a more granular research on focusing and narrowing down on these issues would be extremely interesting to see like what happens across different jurisdictions and different markets to better understand the private provider behavior, and then to also think about the policy responses to these issues. And the policy responses, like we had the presentations, and definitely like in Indonesia and Georgia, it features that there were some exogenous factors that have impacted the market developments, which definitely feature in these 2 presentations. But we don't know exactly what the impacts were beyond what we have seen in the presentations, that growth on the supply side, increasing the utilization, but also with these growth of the private providers in the market, also some challenges of how purchasers reimburse the providers and how they are reimbursed, and what is the quality outcome of such policy decisions has to be explored, especially when UHC is on the agenda globally and we'll have to move forward with it. Thank you. I'll stop here and give more time for the questions and answers.
Perfect. Thank you so much. So a really interesting set of reflections there. I think I'm going to next open things up to the floor. So feel free to raise your hand if you've got a question, either using the Zoom hand or your own hand if you've got your camera on. And who would like to go first? I think, Rebecca, there's one question for you already in the chat, which is actually from George, saying, was market regulation a policy priority for the government of Indonesia, and what did it entail? So would you like to start off by responding to that?
Sorry, I was having some technical difficulties. I think my colleagues would be better placed to answer this. So I will also put in a small plug. We did have this focus on the private sector was just one part of a broader study on the impact of JKN. HP Plus and TMP2K also looked into the financial sustainability of JKN, equity, utilization, quality of care. We had some more specific investigation into MNH and FP care, efficiency, and the impact of health on the economy. So though there's a link to our project site with all of our reports and briefs on the study, and hopefully you can access that link. If not, I can put it also into the chat.
Great, yes. Please do. So, well, we don't have questions from the floor at the moment. Keep thinking of them. But can I just see, would any of the speakers like to respond to anything raised by the discussants? Any reactions to their thoughts? Just put your hand up or give me a wave if you'd like to come back on any of those. Or I see Cara has a question. Should we go first to Cara and then maybe we can come back to you in a moment? Cara, over to you.
Thank you. Thank you, everyone. Those were great presentations. I enjoyed them enormously. So I kind of want to go back to the speakers on the question that Soren asked about what is too much competition in these very different types of markets. So for the small, medium-sized kind of service providers in Tanzania that Tim spoke at, there was a sense that competition, that too much fragmentation, too much competition might lead to induced demand and overuse. But Sarah, for pharmaceutical markets, maybe that's just not a problem because of the nature of the product. So, so it really goes back to this question about, what do we do in markets that are too fragmented, and which are the ones we should worry about first and focus on first? Should we not worry about the kind of commodity markets and then worry more about as the kind of information asymmetries increase? Should we be worrying more about excess competition for those more complex services?
Great. Who would like to respond on that? What is too much competition? Is there too much competition in your market? Sarah, go ahead.
So I think I agree with you, Cara, that there might not be a problem with too much competition, but I was thinking about a lot of the interventions that there's interest in for these types of markets, particularly around malaria case management, involve a lot of training and direct supervision of outlets. And I'm thinking particularly around the introduction of rapid diagnostic tests, but also accreditation and social franchising. And so when you have in urban areas, 40 providers within a square kilometer, how it will be really difficult to achieve a population level impact of these types of interventions. So I think it's maybe not, we're not concerned about how the markets operate, but I think it does pose a big challenge for how we intervene in these markets. And that's something that looking at these data has really got me thinking about.
Great, yeah, really good point when it comes to intervention. Tim, what about in your context?
Yeah, I think you would, sort of theoretically, you'd expect providers to be incentivized to move on those aspects that are most observable, I guess. Prices are probably quite observable, but I think, I think some aspects of quality are going to be much more observable than others. For example, there's a well-known study from the NHS in the 90s where there was price competition and it had an effect on waiting times. Waiting times are very observable in the NHS in that particular context. I think getting drugs, getting antibiotics are very observable and things that patients often want. It doesn't necessarily correlate though with good quality of care.
It also makes me think about how information makes things observable as well. So waiting time is kind of observable when waiting times are published, right? That makes them observable. And so that kind of public reporting can come into influencing what it is that patients perceive as well as how they value.
Yeah, I really liked Soren's sort of thinking of, what are the impacts for the patient and what are the impacts for the healthcare system of kind of excessive competition, high level competition, or what we're thinking of as fragmentation. But I was interested that you were sort of emphasizing more the good effects for the system and the pushing down the costs. I guess that's the costs of service delivery. Whereas in the work like that we've been involved with Mari and George, we've also been quite worried about the impact on transaction costs of managing contracts within social health insurance when you have multiple providers, as well as other potential quality risks when you don't have enough qualified providers to go around. So everyone's sharing one anaesthetist across multiple facilities. So I can see potentially negative consequences at both the patient level and also potentially at the system level, at the costs of regulating and contracting and supporting. But I like the separation. I think that's a useful way to think about it. Any more comments from the floor? Would anyone else like to raise a question or a reflection on what you've heard, or maybe compare to the contexts that you study yourself?
Well, to say a few words, Catherine, from Georgian perspective. So we saw that in Georgia we had an excess fragmentation and concentration at the same times. And if you go to our longer presentation, you will be able to see the possible implications of the fragmentation. But I will just quickly touch this point. And we thought that the possible implications could be a high cost for regulation and contracting, as you have mentioned, and also the lack of economy of scale, lack of benefits from the pooled procurement, and also the implications for quality of care. So, for example, the qualification of permanent staff and so on, and also the very intense competition for a limited pool of patients may improve the patient experience, but also the adverse consequences, for example, for the kickbacks and etc. So I'll stop here, and maybe George will also contribute here from Georgian perspective.
Okay, I'll say a couple of words that from our observation, so excessive competition or fragmentation has potentially numerous dimensions. In many environments where we know that human resources are in short supply, so competition, especially in the service market, so also requires these human resources to be deployed, and we saw a lot of struggle and multiple employment of individuals across the competitors, which also leads to overworked staff, and that negatively potentially affects the quality. The second issue that we sought from excessive fragmentation is that if we take any service provider as a unit of economy, which has to be sustainable because they are under private ownership and owners have an interest to, if not to maximize their profit, at least to minimize their losses. So they need this economy, whatever microeconomy it is, to be sustainable. In that, they need to balance their revenues with the costs. Would that be related to the labor costs or other inputs or the capital costs? And in that, they do try to use different mechanisms to increase the consumption of the services. And that's what I was alluding to, that may not have absolutely negative impact on the health outcome of a patient, but could potentially have a huge negative impact on the health system by increasing its cost, could have a negative impact, negative societal impact with increased cost, as well as could have a negative impact on the patient if the patient is the purchaser of the services in a given environment. Thirdly, other bigger issues have already been mentioned, and I will not take more time. Over.
Wonderful. Well, thank you so much. And it seems we are out of time. We've reached the end of our session. So I just wanted to say really big thank you to all the presenters for cramming their really detailed and complex studies down to 8 minutes. Very well done. And presenting such an interesting range of material. There are more detailed handouts for the presentations available on the IHEA website. So do go and check those out. A really big thank you to our discussants who have really made me think about all these findings and how we're going to interpret them. That's fantastic. So thank you so much for joining us today. And thanks to everyone in the audience. So please join me by giving a big virtual hand for our presenters and enjoy the rest of the conference. Oh, and you can apparently evaluate the session if you would like to. So go ahead, tell us what you think. But yeah, have a great rest of the conference. It's a real pleasure to be here today.